Out of the mouths of babes. I love this video because I think it speaks better than any of us could ever speak. It's the children, it's the providers, it's the parents that benefit from the services that we provide. So hopefully that gave you a little bit of a framework of what a school-based health center is and how we operate. If nothing else, it provides an outline. I'm going to spend the next few minutes trying to complete that outline and fill it in a little bit for you, and then if there are any questions at the end, please feel free to ask us anything or along the way. I think the first question is, what is a school-based health center? You've seen kind of some parameters. School-based health center is a licensed outpatient clinic. In the state of Connecticut, it's defined by the Department of Public Health as a model of service delivery that provides for physical health services, behavioral health services, and in some communities, dental health care. Every school-based health center represents a model of service delivery, and I think that's really the key here, is that school-based health centers aren't unique to an organization or a certain agency. We're administered by a variety of different agencies. We actually represent a model of comprehensive care for service delivery to children that is located within the schools. What services do school-based health centers provide? School-based health centers provide early periodic screening and developmental testing. That's EPSDT. Basically, EPSDT services are those services that are provided in well child examinations. However, oftentimes for children, they're not comprehensively provided. In school-based health centers, we deal with the behavioral developmental issues, nutrition issues, a variety of comprehensive issues when we address the child. We deal with acute and chronic care issues. We provide reproductive health care services, counseling services, educational groups, patient education, case management and outreach services, referral services, psychoeducational groups, and support groups. We have preventive dental services, which are not in all communities. We have 5 communities that we have dental services in currently. I think the most important thing to know about the service provision for school-based health centers is that our focus is on prevention. Unfortunately, preventive services, as we know throughout history, are not reimbursable, and they're something that's difficult to comprehend and support in the short term because we get a little bit impulsive and impetuous and we want to see immediate results. As we know, prevention does work. The preventive services that we are fortunate enough to be able to provide in school-based health centers are done on-site with very qualified staff and include class presentations on such topics as asthma, obesity, dental care, nutrition, coping skills, stress reduction, STD, HIV and AIDS education, tobacco and substance abuse education, personal safety issues, and healthy relationships. These are powerful topics that help influence the health choices children make as they develop through adulthood. Where are school-based health centers located? There are currently 63 school-based health centers funded by the Connecticut Department of Public Health throughout the state. There are currently 22 located in high school, 17 located in the middle schools, and 24 located throughout the state in elementary schools. More specifically, what communities are school-based health centers located in? Around the state, we have a variety of representation in rural, urban, and suburban communities. The Department of Education, I'm sorry, go back. Can you go back? The Department of Education created ERGs, which are educational reference groups, which divided 166 school districts into 9 groups with similar socioeconomic status and indicators of need. School-based health centers are located predominantly in the highest need ERGs. Another indicator of need, too familiar to all of us here, is that of insurance status. Sorry. Got it? This slide is very important to us because I think what it does show is if you look closely at the 2000-2001 information regarding Medicaid versus the 2001 and 2002 information, you'll see that the Medicaid rate for school-based health center services went from 28% to 39%, whereas the private insured went from 39% down to 28%. That was the year that presumptive eligibility was introduced for the first time. It has significant impact on the number of kids we were able to enroll in Husky and therefore provide for Medicaid service. Over the 4-year span, Medicaid among school-based health centers increased from 28% to 41% of the population. Uninsured number remained the same and steady throughout the 4 years that we've looked at. We've discussed this at numerous ends with DSS and a variety of different agencies, and we have a variety of different variables that impact that number. Most of the schools suggest that there's an increase in undocumented kids, that a lot of services, a lot of insurance companies a lot of employers offer dental insurance, and parents choose to opt out or not to accept the dental insurance, which leaves them uninsured for dental coverage. There's an increased cost, there's poor access to behavioral health care service, there's changes in insurance status for parents who change from position to position, which delays their coverage. So those are just some of the reasons that we've identified the high number of uninsured. In regards to school-based health center student enrollment, in 2003-2004, there were 59,956 students in schools with school-based health centers. Of these, 70.4% were considered enrolled in the school-based health center. Enrolled meant, in school-based health center terms, that the parents had signed a parent permission form allowing the child to receive services through the school-based health centers. Of those students enrolled, 46.1% utilized the various medical, behavioral, or dental services. As we look further at which services are being utilized, we can see that based on the 2003-2004 visits, there were 62.3% that were made up, that were comprised of medical visits, 33.5% that were comprised of behavioral health, and 4.2% that were dental in nature. The considerations that we have to be concerned with in this slide is that it's a little bit skewed. The 4.2% for dental doesn't represent the need. As we know, dental health care needs in this state, especially among this high-risk population, are absolutely at its highest. The reason this number appears low is because out of the 18 communities that have school-based health center, there are currently only 5 that have dental programs, 3 full restorative programs, full dental clinics, and 2 preventive programs, which is why this number is as small a proportion as it is. Out of this total number of visits, it's also important to know that everybody asks us what percentage of your visits are reproductive health in origin. Only 8.1% of our total medical visits are reproductive health in origin. I think the final consideration is the total number of visits that we saw that year. Based upon the 2003-2004 statistics, we saw 88,773 student visits that year. As for the school-based health center role in the provision of medical care, our goal is not to serve as a primary care provider, but to ensure the health status through our collaborations with primary care providers. So what you see on this slide is the student who enters into the system, sees our practitioner, and hopefully is referred out into the community to area safety net providers, community health centers, clinicians, immediate medical care centers, and primary care providers for medical homes. Unfortunately, sometimes that's not always the case, and we do end up seeing those kids, but our focus is to connect them with an in-home medical home facility. Mostly for medical services, we provide acute and chronic care management, episodic care related to access, transportation, and insurance status. We provide physical examinations and, as we said, developmental screenings and testing. The role of the school-based health center in the provision of dental care varies among communities. As we talked about, we have 3 communities that have full dental clinics and 2 that have preventive programs. We all know the barriers that are following us in the provision of dental care for children, especially regarding the uninsured and the underinsured. Our issues include missed appointments, lack of transportation, lack of coverage, poor time off for parents, too few providers, which leads to long waiting lists. There's an increased number of visits required during dental exams, not just the initial visit, but then a return for the screening, for carie, the x-rays, and then for the carie filling itself. Because of so many visits that are required, oftentimes parents can't keep up with that number of visits, and these kids end up falling off track in following through on their dental care. But the most important thing is probably the reimbursement rates that the state is all too familiar with, that is low for Medicaid clients, and thereby not an incentive for providers to take the Medicaid eligible kids. However, having said all of this, school-based health center dental programs have a huge impact on reducing the rate of decay in the school-based health center communities with dental located within their schools. I think if we think back to the time where we had, and I'm probably dating myself, but way back when we had the spit and swish program in schools where you actually walked down the hall, got in line, remember those? And you actually got a little cup and you did your spit and swish and off you went. You had to swish first. Good point. Swish and spit is probably much more effective. We're actually coming back to those times, because access being what it is, cost being what it is, it does seem to be the most cost-effective prevention in dental decay. As for behavioral health care in school-based health centers, this is another area of concern that the state is obviously very aware of and working with the Kid Care rollout with DSS. We've been working very closely with them, as have a lot of others throughout the state. The difficulty with behavioral health services is that we've seen over the years an increase in the severity and nature of behavioral health issues facing kids. With this, there are few providers. There are less providers out in the community that these kids can be referred to. You add on to that issues of access, transportation, communication, confidentiality, and what I call the hot timing of it all, which is the fact that when kids are in school and an issue comes up, that's their hot time to talk about that issue. Oftentimes, if kids wait till after school, if they wait till after their event, it's not as hot. The window of opportunity is narrowed, and these kids often don't follow through discussing with outside providers, seeking their doctor's help to get a referral out to behavioral health. Located within the schools, school-based health centers have the unique ability to offer social work services on site, so that when an issue hits a child, they can come downstairs and we can deal with it right there on site. There's an increase in the number of services that we provide out to the community, but because of the severity, they're often referred out in crisis, suicidal ideations, they're having breaks, they're bipolar. They're in a unique position that once we refer them out into the community, the difficulty in finding the provider, getting the kids set up, and then having them re-enter the system allows for a lot of disruption, and we lose kids a lot in that transition, which is difficult for us. And it actually, in the long run, it affects the kids tremendously. Excuse me. Where are the successes? We often ask that of ourselves. Thanks to the Health Foundation of Greater Cincinnati, we finally have a lot of concrete evidence to support the effectiveness of school-based health centers. It's one of the first reports that we've seen that has been this comprehensive in origin. It was released in 2005. One of the items that I extracted from their report was related to the decreased cost of hospitalization due to asthma and the implementation of school-based health centers. As you can see by the slide, after their school-based health centers opened up, there was a significant decrease in the cost of hospitalizations for asthma-related care. These findings mimicked some of the findings that we had through the Connecticut Association of School-Based Health Centers in a report that we filed in 2002. In that report, we found that a student seen at the emergency department for asthma treatment, typical asthma outpatient care, would cost about $350 for that visit versus $22 per visit if they had been seen at the school-based health center. In that case, the hospitals must absorb the cost for the uninsured child, and the child obviously has episodic care. It's not managed, it's one-time care, and they're discharged. Once seen at the school-based health centers, our benefits are that we have programs, 8-week, 12-week programs for asthma education that kids are enrolled in, take part in. Through these programs, we teach kids about their asthma, their triggers, how to manage themselves, and how to prevent hospitalizations and future doctor visits. The most important thing that we do is that we return these kids to class. We can treat them on site and return them to class. To summarize facts for school-based health centers, school-based health centers remove barriers to care, such as transportation, unnecessary time off from school and work for preventive and acute care, and canceled appointments. School-based health centers, along with community health centers and emergency departments, serve as safety net providers for Connecticut's uninsured and underinsured children. School-based health centers are cost-effective, as we've well proven with the asthma slides and our statistics from Connecticut. Finally, school-based health centers have had a significant impact in the treatment of oral health prevention and decreasing the rate of oral health decay. So what can school-based health centers prove? We can improve the children's health status. We can prove that we're cost-effective. We can prove that we increase the number of safety net providers for the state. We improve access to care. We serve a vital role in identifying referring patients to medical homes, behavioral health specialists, and dental specialists. The most important thing we do is we keep kids in school. Recommendations: research additional funding for school-based health centers by matching state with federal SCHIP funding. Currently, there are 2 states, Michigan and Maine, who have been successful in writing waivers for federal funding to match their SCHIP funding. That's matched their school-based health center funding in each state. For us in Connecticut, we currently receive $6.2 million in state funding. That would be a tremendous increase in the number of services we could provide to these students. Support the reimbursements for mental health codes that are more preventive, educational, and short-term in nature. And support the creation of a task force between DCF, DSS, DPH, CAS, and the Department of Education to ensure that the provision and coordination of services to school-age children is seamless and as cost-effective as possible. Finally, something near and dear to our heart, our motto from the Connecticut Association of School-Based Health Centers is that healthy kids make better learners. That's our commitment to Connecticut's children and the children we serve in Connecticut. Thank you very much for allowing us to speak today. And I have a comment from our Vice President of the Association, Mary Ellen Haas from Stamford.
Good afternoon. Just 2 brief comments, especially based on something that the speaker said in his introduction. I think it's important for you to note that Connecticut is a leader in the country. The National Assembly on School-Based Healthcare was actually founded by some of the people in this room from Connecticut. And as we look at the over 1,400 school-based health centers in the country, Connecticut is the only state that mandates that our health centers have to be comprehensive, meaning they have to have mental health services as well as medical services. So I think it's something to note and something to be proud of. And lastly, when I heard the speaker talk about the article in the New York Times, I think what is most impressive to me about working with youngsters in school-based health centers is involving them in the responsibility for their own care. Unfortunately, many of our children are raising themselves. And so it's really important, the preventive piece of it. And I want to just draw your attention and do a small commercial, because we had an article in the Stanford Advocate about a group of youngsters who started a nutrition club with one of our nurse practitioners called the Healthy Eating Club. The Associated Press picked it up, and last Wednesday, CBS Morning News spent the day with them at West Hill High School. This Friday morning, on the CBS News show at 8 o'clock in the morning, they're featuring a group of kids who came together with their school-based health center, came up with some very creative ideas from kid to kid to reach youngsters in that school. So I think we can never underestimate the power of prevention and never underestimate the power of prevention from their own peers. Thank you.
Thank you very much, Deborah. What I'd like to do is to see if there's any comments by any of the people around the table or any questions. So, Speaker Ammon.
So on your recommendations, the last one there, you said support a creation of a task force. May I suggest, since I know one of the things we are eventually going to get to, because I know Dr. KJ Lee can't wait to that part, eventually when we do all our education presentations, and that's what I think we've all been doing over these meetings, is to break up into these working subcommittee groups. Would it suffice you, instead of us now creating another task, would it suffice you if we could use some of the members, which we have plenty, I think, to formulate that task force right with this group? Would that?
That would be wonderful.
Okay. I just wanted to, okay, good, thank you. Thanks.
Very good. Thank you, Mr. Speaker. I have a couple quick questions. Besides the research that you had in Cincinnati as far as, the drop-off and the cost as far as asthma, have you seen any tangible results as far as the number of absenteeism, better academic performance in the schools that have school-based health centers actively in their school systems?
We see that locally. We haven't studied it as currently from the state associations level, but district by district, they do analysis, and yes, there has been significant impact on that.
Thank you. And then, just for clarification, I had a question. One of the things that you mentioned is that, with the school-based health centers have reduced some of the barriers, but in a previous slide, you said that these same things were barriers. So if you could kind of comment on that, that would be appreciated.
I think there are barriers to care that face our children and their families every day. We address those by being located in the school to some extent and having services, but our services are limited. We're not a primary care provider. And for certain services, like, for example, dental, for a school-based health center that does not have a dental program, one of the barriers to care is if I have a child with an abscessed tooth and I'm trying to refer them out into the community, getting them to a provider in the community that has dental care and restorative care and emergent care is very difficult. So the barriers of transportation, language, access, cost, insurance serve as barriers for programs that don't have those services or aren't able to provide those services on site.
Thank you. And then just one final question. Is every child that's within the school system eligible, based on parental consent or guardian consent, or is it still an eligibility or some kind of criteria?
Any child in the school system that the school-based health center is housed in is eligible to enroll in the school-based health center for services.
And then, I'm sorry, go
I
ahead.
just wanted to make a comment, Representative O'Connor. School-based health centers started in the early 70s in the Midwest, and they sprung up primarily as adolescent health centers. And it had nothing to do with need as much as to do with that adolescents don't seek health care. And so that is one of the reasons why we see youngsters, no matter what their economic status is within the school, because adolescents typically are very under-cared for.
Thank you. And then, just one follow-up to that. As far as the process by which they see one of the providers, how do they schedule that during the day? Is there a set time that they're open, or is it during lunch or right after lunch or recess?
School-based health centers actually mimic the school schedule. So they're open the same hours of operation that the school are. Some are expanded throughout the day, so some are actually open longer hours and have after hours so that they can do family counseling and have parents come in later. But all school-based health centers are open through the school course of the school day and accessible to kids. Most students are scheduled, if we can pull them out of class, on study halls, lunch periods, before school, after school. If it's a short-term visit, we can try and scoot them in prior to lunch, after lunch. We're going to try and take them out of as few academic classes as possible. That's certainly not our intent, but you get to a point where sometimes you have to weigh out what the issue is and how important it is, and sometimes if they're not able to learn because of their illness or their issue, then it's far better that they come down and we can resolve it there and address it at that point in time. But most visits are scheduled during their times of non-academics. And I was just reminded that most of the school-based health centers also are located in schools that have a school nurse. The school nurse actually does a lot of the triage for the school-based health centers, so that most of the entry goes through the school nurse's office. School nurse will refer down to the school-based health center. Kids can self-refer themselves, certainly, but it helps as a gatekeeper for us so that we don't see every child with every illness who may want to get out of school more than they are ill. So that's our kind of our gatekeeper within the schools.
Okay, so does that mean it's more of an on-demand system and the nurse acts as a gatekeeper, or are there scheduled appointments that might be a week out, or?
Both. Yeah, if we see a child, especially if we're seeing them for, let's say, a service and we're planning a follow-up, we'll schedule the follow-up visit at that point with the student, and the school nurse is pretty much out of it at that point. So we'll follow up individually with the student.
Thank you very much. Or, Chairman Sayers.
Thank you. Thank you. Do you bill for all your services?
No, there are services that we can't bill for. Many of the preventive services that we provide we're unable to bill for.
Such as?
Classroom presentations, where some of the psychoeducational groups that we provide.
So more health education that you don't bill for because,
Correct.
right, but that's health education which should be part of a school curriculum.
Not necessarily. Not a lot of the group work that we provide. A lot of the group work we provide are skills, lifestyle skills, anger management, smoking cessation, important types of programs, educational programs that they don't have within the scope of the school curriculum to operate on a long-term basis. We also aren't reimbursed for case management skills. Case management is huge. I'll give you an example. We have, let's say, a suicidal student, and the student cuts him, let's say, has made an attempt and taken pills. They enter the system through the school-based health center. They see the nurse practitioner. The social worker's called in. As a team, they work collectively with the school system to call the parents, get the parents involved, refer the child out, and connect the child. This whole process can take up to, let's say, 3 to 4 hours in some events. During that time, none of that is billable. We have 2 professionals who have worked with that child, and none of that time is billable.
So schools that do not have a school-based health clinic, how do they, what pays for those services in those schools? Because they do provide some of those same services.
Many of them had outside grants. They're grant-funded. It's a grant-funded program for smoking cessation, let's say. They have a grant for obesity. As far as for the services for the more extreme, they're going to call 911. If they have a suicidal child, they'll call 911.
But, because I know in my schools which do not have school-based health clinics, for instance, they do groups, the Elephant Club, which is a substance abuse group for kids and who have parents that are substance abusers, and a number of other types of things, including the anger management. And that's done through the school social worker, just as part of the usual school curriculum.
Sure.
Just to comment on that, the school social workers, as you probably know, are mandated to see children who have an individual educational plan, an IEP. So they're mandated to see special education students. I'll speak about the system that I'm in Stamford. Currently, we have 2.5 school social workers in each of the high schools, and they are inundated with the youngsters that they have to see. So probably 80% of their time is spent in special education. We pick up the slack on a lot of the crisis intervention. To respond to the health education question, health education has been cut back dramatically. I think that's why we were asking in that previous slide to come together with also the Department of Education, because their resources have been cut back tremendously in the area of health education. In our system, again, we have coaches that are teaching health now, and it's a very small window of time. So we augment a lot of that. Our nurse practitioners go into the actual health classes to help augment to treat about sexually transmitted disease, et cetera. So we see ourselves, and we are, and act as an adjunct to what the school is able to offer because their resources have gotten dramatically reduced over the years.
Okay. And one of my concerns with that is because that health education is something that a school nurse should be providing. The problem is that with a lot of our school systems, my own in particular, the school nurse is serving more than one school
Absolutely.
and really has only the opportunity to come when there's a sick child within the school rather than do the health services types of things that the health teaching types of things that they should be doing. If a child comes now to see you and they don't have Husky and they would be eligible for Husky, does someone help them apply?
Yes, we either refer them out or, depending on the structure of the school-based health center, some school-based health centers have individuals that are on-site and work as outreach providers. Many of us refer out to community. I know I refer out to our local community health center that has an outreach worker and a Husky enrollment provider that will work with the family to enroll them in Husky.
Can I-
Go.